Thank you for joining us for the 4th Annual Global Summit on Kidney Innovations. Global Kidney Patient Voice, the key to accelerating innovation. A collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Richard Knight, and I serve as president of the American Association of Kidney Patients. I'm a former dialysis patient and was blessed to have received a kidney from a living donor over 16 years ago. I first joined AAKP back in 2008, and after 2 years on dialysis and having a transplant in 2006, I considered myself to be very, very fortunate. And I was seeking a way to be more engaged and involved in the kidney community. And that's when I filled out an application to join the AAKP Board of Directors. And I have been very, very pleased since that time. As I look over my past involvement with AAKP, I've had the opportunity to work with the Kidney Precision Medicine Project, which is over at the NIDDK, National Institutes of Health. I've been involved in the Scientific Registry for Transplant Recipients. I've attended numerous events and have had the chance to work with some of the best and the brightest healthcare professionals and patients who are clearly committed. But the most important thing that I feel very, very thankful for is the opportunity to voice my concerns to those on Capitol Hill who are responsible for making the laws that will have an impact on our patient lives. And having done so, I invite and I encourage all of you to join us. We need to be as united as possible. We have many initiatives that will allow one to do so. And as a member of AAKP, you can do the same. It is critical now that we as patient consumers raise our voices and create the demand for diagnostics and devices and biologics in our respective independent countries. Through AAKP Global, which was launched in 2019, AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the opportunity to save more lives. We believe that a united patient voice can drive innovation and policy decisions that determine timely regulation and payment for new and safe care treatments. Globally, we work with patients, medical professionals, researchers, and medical industry allies to cultivate a united consortium that is in fact led by patients. AAK believes that this international consortium can advance innovation and change kidney care in countries where healthcare systems and infrastructure do not support patient consumer choice or access to many care treatments. With that backdrop, I am pleased to introduce today's session titled Science and Discovery with Global Implications. Our first speaker for this panel is Dr. Navdeep Tangri, who is an attending physician and associate professor of the Division of Nephrology, Department of Medicine, and Department of Community Health Sciences at the University of Manitoba. As a researcher, a few of his many focuses includes improving clinical decision-making for patients with advanced CKD and creating and validating the kidney failure risk equation to predict the need for dialysis in patients with advanced CKD. Today, Dr. Tangri joins us as principal investigator of the CARE-ME study to share insight on this research and urgent unmet need in diagnosing and screening people globally. Dr. Tangri, I turn it over to you.
Thank you. Thank you for the invite to be here. I'm delighted to present at the AAKP Summit today, and I'm so happy to talk about a topic that's near and dear to my heart, early diagnosis of chronic kidney disease. I'm Navdeep Tangri. I'm a professor of medicine at the University of Manitoba, and it's just great to present today with my colleague, Dr. Nickerson from the University of Manitoba, and with so many esteemed investigators and patients and advocates for everyone with kidney disease. So I'm here to talk about chronic kidney disease because it truly is a global public health problem. It affects 840 million patients worldwide, and that prevalence ranges from 1 in 7 to 1 in 10, no matter where you are in the world. In reality, it's probably a billion people and $1 trillion spent on kidney disease. It truly is a billion-person, trillion-dollar problem. And it's not just a problem of dollars and cents, it's a problem because of all the morbidity and excess death that kidney disease causes. And this burden's been rising for at least the last 30 years. When you look at chronic kidney disease in its own, or whether it's due to diabetes or hypertension or other causes, over the last 30 years, the contribution of chronic kidney disease to overall morbidity and death just continues to grow. And it's imperative that we find a way to slow it down or reverse it entirely. So why do I think this is a problem, and why haven't we been able to get ahead of it? Well, it's because when you look at the old staging system for kidney disease, and based on the GFR part for sure, almost all the patients are in CKD stage 1, 2, and 3. This is US data from NHANES, looking at about 14.5% of the US population. And what you see is stage 1, 2, and 3 are 14.4 out of 14.5. So the prevalence is really high in stage 1 to 3. In contrast, the awareness is completely the opposite. The awareness only happens at stage 4 and 5. At stage 1 to 3, where 14.4 out of 14.5% of the patients are, less than 20% are aware of their chronic kidney disease diagnosis. So when they're not aware, how can they act? So here's why I think we have a problem with chronic kidney disease and its management, and why we're here today. So CKD, most of it is stage 1 to stage 3. And that's asymptomatic. The patients, they're feeling something, but they're feeling tired. They're feeling kind of, I'm not able to do as much as I used to. Maybe I need an extra nap. Maybe I can't work with my children or grandchildren as much, or play with them as much. But these symptoms just get dismissed. So it just gets called an asymptomatic disease. The diagnosis occurs when the symptoms occur, which is stage 4 and stage 5. Now, by the time you get there, it's just way too late. Once that late stage is reached, there's just so few opportunities to delay further progression. So all we're doing is just playing the delay game. We are lost the window to truly prevent dialysis. And that's why what I'm really passionate about is detection of CKD to optimize patient outcomes, active screening, finding patients early, and treating them early with treating their diabetes, treating their hypertension, treating their CKD, and preventing cardiovascular disease and progression to kidney failure. How does the awareness of CKD, we said awareness is a big problem. How does it compare to other countries? Well, when you look at chronic kidney disease, 77% of the general public doesn't know about chronic kidney disease. In contrast, in diabetes, it's like 40 something percent. In heart disease, it's 40, it's 40 to 50. In cancer, it's 40. Alzheimer's, it's 50. So it's not just that people are not aware of any chronic disease. People are just disproportionately unaware of CKD, and so much work that the AAKP has done, that the NKF continues to do, and all of us as providers need to keep doing to make sure people know that this is an important public health problem. So again, to summarize this in one picture, so this is a KDIGO, or a global guideline meeting that I was involved in, and we came up with this photo illustrating the CKD stages, stage 1 to G5, G1 to G5, which are running across your screen. And what you see is that there's so many things we can do to improve prognosis in CKD. Lifestyle modification, RAS inhibitors, blood pressure control, statins, Sgld2 inhibitors, GLP-1, finerenone is a new drug that's in there treating metabolic acidosis. But all of these things, the benefit from them thins out as you get closer to stage 4 and stage 5. So it just hammers the point home again that all these tools we have in our toolbox, we cannot apply them if we don't pick up patients early. And here's a nice illustration on why this matters. So on the y-axis on this slide, you have a patient's GFR or kidney function, and on the x-axis, you have time in years. And what you see is that if we act early, we have a big effect. We can delay kidney failure by 4, 5, 7, 10 years. Whereas the later we act, it's just the window just closes and closes. It comes down from a matter of delaying dialysis or preventing it entirely by a decade or more to just moving the needle by a few more months. Exactly. So 4 years, 2 years in this example, but really I think it can be a decade or longer or just a few months. Early identification and intervention, and that's really what I'm here to speak about today, and that's what I've spent my career working on, can truly reduce the morbidity, mortality, and the financial burden of chronic kidney disease. It's finding patients in stage 1 to 3 that's really important. 4 to 5 is just way too late. And not only does this make sense for patients who we're here to talk about today, who is my audience today, who I'm thrilled to speak with, but also to the payers in the room, to the people who hold the dollars and the purse strings. If you want to delay and prevent the cost of CKD, find patients early. When you're getting to stage 4, that's where we're moved now. We've moved from dialysis to talking about stage 4, stage 5 with these value-based care models. Even that's too late. To truly impact the cost curve, we have to act in stage 1 to stage 3. So why aren't we acting? So here's what I think the main barriers are. First, we are not getting enough testing of albuminuria or urine ACR. Providers, despite 2 decades of recommendations, do not consistently order a urine ACR. The urine ACR and GFR are not reported together, and so they're missing high-risk disease early. So if you just rely on GFR, you'll catch disease late. Second, there's this fatalistic idea that CKD is untreatable, unstoppable, that it's just a complication of diabetes and hypertension, that's not a disease on its own, and this needs to stop. Chronic kidney disease is its own entity with its own treatments that work whether you have diabetes or not, whether you have hypertension or not, and we need to get this message across. And when we establish it as a standalone disease, we will make it a priority. It'll become a priority alongside diabetes, hypertension, mental health. Right now, it just falls way further behind. We know it falls behind because when you look at patients with chronic kidney disease in the US, despite, again, 2 decades of data, RAS inhibitor prescription rates are still hovering around 20%. I mean, this is unbelievable, right? And Sgld2 inhibitor rates are like less than 10%, 0.1% in this analysis from 2019, but still 2-3 years later, still hovering around less than 10%. What about Sgld2 inhibitors? So Sgld2 inhibitors, as you know, are a novel group of medications which have shown just unbelievable cardiorenal benefits in randomized trials. They truly have transformed the management of kidney disease, but they just don't get prescribed. Even in Canada, where I work, where there's a universal healthcare system, less than 12% of patients with CKD get a prescription for Sgld2, even ones that have high risk for CKD. So something needs to change. What new data can I show you today? So this is a study that I had a chance to lead, and today I wanted an opportunity to highlight this. So we did a study of 11 patients from 11 countries of 2.4 million adults. And we wanted to look at what is the real prevalence of CKD across these 11 countries, and what is the risks, the characteristics, and what's happening to these patients in these 11 countries. We wanted to show consistency. So first, really important, we found that measured CKD, which is CKD by the level of GFR, was 2 to 3 times more common than diagnosed CKD, which is somebody putting a CKD diagnosis in a claim or in the electronic health record. Which tells you, you can see here on this slide, there's 1.2 million patients here with measured CKD and only 573 with diagnosed CKD. So it's at least 2 times as common. So if we're relying on the doctors to code it, we're missing half of kidney disease. So somewhere in the workflow, we have to make it automatic. If somebody has 2 eGFRs less than 60, or if they have 2 albuminuria values greater than 30 milligrams per gram, they should be coded as CKD. It should enter the problem list. What we found, to summarize, was that 1 in 10 adults in Europe, Canada, and Israel have CKD. I think it's 1 in 8 or 1 in 7 in the United States. And when we looked at people with lab-confirmed CKD, 2 out of 3 did not have the diagnosis. And only 60% in these countries, in this cohort, got a RAS inhibitor, a medication that's been around for 2 decades. I bet if we looked at Sgld2 inhibitors, it would have been less than 10%. And CKD was deadly. 9% of individuals died with CKD during the study period, and hospitalization rates for heart failure and CKD events were very high, 10% and 9%. This is my favorite slide of our paper. We know, and this is speaking to all the payers in the room and anyone who has communication with any of the payers, CKD is associated with high healthcare costs, but you have to look in the details. The devil is in the details. The dark blue line represents the cost from progression of kidney disease, and the light blue line represents the cost from heart failure. The red and orange lines represent strokes, heart attacks, or PAD or PVD. What this analysis shows is that when someone has kidney disease, almost all of their morbidity, their cost burden comes from either progression of their kidney disease or from heart failure. So that's what we need to focus on. Less so, strokes and heart attacks, they're actually not as common as we think they are in CKD patients. It's heart failure and kidney disease. And on the next slide, I'm going to show you how we can change the trajectory. We today have at least 3 important disease-modifying therapies to reduce CKD progression and heart failure in patients with CKD. RAS inhibitors slow CKD progression by 30%, reduce cardiac outcomes like heart failure by 24%. Sgld2 inhibitors slow CKD progression by 38%, heart failure hospitalizations by 43%. Finerenone slows CKD progression by 23%, slows heart failure hospitalizations by 22%. All of these benefits are additive. All of them are additive onto each other. So if you think you find that patient with CKD early on their trajectory, you get them on, you find they're a high risk patient, you get them on these 3 medications, you can change their lifetime CKD trajectory. They might never be on dialysis, and they might never make it to the hospital with heart failure. So today, I'm much more optimistic about the impact early diagnosis can have. And that's why I believe early diagnosis is imperative. And that's why I titled this talk, Early Diagnosis of CKD. So thank you for your time and attention. It's really been a pleasure speaking with you today. And I'm so glad that we're working on the same team, advocating for earlier diagnosis and better treatment of our patients. Thank you.
Thank you, Dr. Tangri. We appreciate you taking the time to explain this clinical trial to us and how it supports early identification and intervention of CKD.